Um, Leukemia, anemia, this is very common these days, and not many people talk about it. It's been there for a while, and especially with the COVID around and deep vein thrombosis, is been there. People sometimes neglected it. So that's the main reason I thought I'll bring a specialist and let's talk and let's make it clear here. So please welcome our special guest on the show, Dr. Abu Sitar. He's a consultant hematologist and hemato-oncology. Abi, thank you very much for being in our show.
Thank you.
How are you doing today?
Thank you very much.
Okay, let's talk about you. Who are you?
I'm a consultant hematologist and hemato-oncologist. As you said, I have been in this field as a consultant for the last 10 years, spent 5 years in training before that. And I currently work in Essex.
Excellent. Right. Do you speak Arabic?
Yes.
Okay.
Yes. Yeah.
Where does your family come from originally? Do you?
Well, I'm originally Palestinian.
Palestinian, all right.
I was born
because I never had anybody from Palestine. It's very
No,
interesting for our viewers to
Yes.
see someone from Palestine and you're here.
Yes, probably not too much Palestinians in hematology either, so that makes it
Exactly, yeah.
rarer. Yes.
So you're from Palestine, right? Okay. Where did you study? Did you study in Palestine or did you?
Well, I did my postgraduate training in the United Kingdom, but I did my primary medical degree in Tripoli in Libya.
In Libya.
Yes.
Do they have medical schools in Palestine at the moment, or is it?
Yes, yeah. They have medical schools in the West Bank.
All right.
I think at least there are 3 medical schools, and there is a medical school in Gaza Strip as well.
So there are 4 medical schools still?
Yes.
They are all running normally?
Yes.
Oh, that's good to know that. Thank you. Okay. Why did you choose hematology? What was the interest behind it?
Well, that's very interesting question, in fact. Since I was in medical school, I found the hematology topics are more interesting. And hematology in this country combines clinical and laboratory work. And so it provides an opportunity for variety in the work experience. And then when I did my training as a junior doctor in this country, I was exposed to more hematology, and I decided by the time that was going to be my long-term career.
That's actually it's a very good subject, and a lot of people are interested, especially when you say about blood cancer. People think, wow, this is a killer, that I'm going to die. But it's not anymore, isn't it? It's a lot. We're going to talk more in detail.
Yes.
So that's why you are here. You're going to explain about it. Anyway, this is a live program, so if you have any question, you can always call us on 0203 515 5788. Or otherwise, you can always write to us on our Health Talk Facebook page, Health Talk with Dr. Akram, or YouTube, Health Talk with Dr. Akram again, and Instagram or Twitter. So we'll come back to you with the answers. Okay, let's go talk about what is leukemia or blood cancer.
Well, leukemia is a term which came to existence from the early 50s, and leukemia in simple terms means white color, and this is because of it's a disease or malignant disease of the white blood cells, it is a very heterogeneous.
Let's clarify a bit here before we go ahead, because there'll be children watching our programs as well. Okay, let's say what kind of blood cells are around in our body.
Okay, so simply thinking about blood, there are 3 types of blood cells.
I'm going to hold you there. There's a caller coming straight away in Towland. Hello?
Hi, can I ask one question, please?
Definitely. What's your name, please? Where are you calling from?
I'm not telling my name.
That's fine. You could say where you're calling from at least.
Sorry?
Where are you calling from? What part of England or?
Yes, England.
Oh,
Yeah.
okay, good. Thank you. Yeah, go ahead with your question. Thank you.
Yeah, thank you so much, first of all, you both of them, because it's really important. And I have got, when my elder, the daughter is born, 2005, then I've got the hernia. Then I think, I'm not sure, after that, I've got operation. Now, then my hernia is come back again. I'm feeling my belly button here is a little bit lump, slightly bigger, like egg size. Then I'm feeling pain again. Then I see the doctor. I'll call the surgery. They said, can you come? Then I'll book an appointment for you if we think you need it. Then they will refer hospital. Then I'm going here. Then they will do the ultrasonograph. And they said, you need another operation. So my question is, do you think, when I leave my phone, you give my answer, do I need hernia operation again, or can I avoid the hernia operations? And is any activity, if I do that, can I do this one without operation? So can you give my advice? Which one is good for me? Okay. Because now is lockdown. They said, we can't do anything else, but you are the waiting list. So okay. I'm thinking I'll talk with the hernia specialist. They will refer for me hernia specialist. But the lockdown time, sister, they said everything is canceled. Yeah. But can you explain me, what can I do now? And can I do any exercise, then reduce, feeling a little bit better? Or do I need, every time when I've got pain, do I need again and again operation? So I know it's not good. So please, can you give this answer, please?
Thank you very much. It's a very interesting question. Yeah, it's a very interesting question, sister. Have you heard the question?
Well, I haven't heard the whole story, but she's going to have a hernia operation.
Yeah, exactly. So this lady had a delivery 2005, I think, she had a baby. Then since then she is having a hernia, and she had an operation once. But the lump is coming back. It's somewhere around the belly button, and now she has gone to the GP, it looked like, and the GP said she might need another surgery, and she's still got pain around there, and actually she is asking what to do. Can she go for another operation, or it is? Are there anything else you could do, exercise, things like that? It's a surgical question, so it's not from hematology, but we can combine, we can answer the question.
I think the only advice I would add from the hematology point of view is if she's going to have surgery, which should be decided by the GP and the surgeon, that any surgery can be complicated by risk of thrombosis, and she should be reassured that in the UK hospitals there are strict policies in place to prevent the history of thrombosis, but we always advise the patients to keep well hydrated and keep mobile immediately after any surgery. That's what I can add from the hematology point of view.
Thank you very much. Yeah, so that's good. I think what I could add here is, look like you have a hernia, so there's two ways. If they have done an ultrasound, as you said, the ultrasound will generally say the major problem with hernia, generally it is fine if a hernia is there, but sometimes it can get obstructed, or internal organs can pass through that hernia sac and they can get obstructed. That's the time it becomes an emergency, you need an operation. But sometimes if they feel like it is going to go that way, and your doctors might advise you at that point, okay, go ahead and operate and fix it. Once it fixed, it should not come back. But again, it comes back. They call it recurrent hernias. If it comes back and you go back again, they put a plastic sheath on top of that hernia area and they suture it, and usually it stops. In most people, in 90%, it stops there and they don't come back. But anyway, there is a good video on Health Talk with Dr. Akram YouTube channel about hernia, and please go and watch there and write something there, and we will come back to it in more detail. Thank you very much for your call. Okay, let's talk quick little bit about leukemia, and it's time for break.
Yes, yeah, sure.
Okay, yeah.
So
what kind of cells?
The white blood cells are the cells in our blood, which have mainly one function, is to fight infection.
White blood cells.
Yes, and then we have the red blood cells.
Red blood cells, yeah.
Which carries the oxygen to our various organs.
Yeah,
and we have the
body,
platelets, or simply called the clotting cells, which stops us from bleeding.
Those are three major
cells. Yes.
And leukemia,
leukemia, where if there is cancerous proliferation of the white blood cells, while the excess of the red blood cells, we call it polycythemia. Deficiency of red blood cells, we call it anemia.
Anemia.
And the platelets, if they are low, we call them thrombocytopenia, while if they are high, we call it thrombocytosis. And important people, they don't mix between thrombocytosis and thrombosis.
So when people say blood cancer,
yes,
what do they generally mean?
Well, blood cancer is rare disorders. They are malignant tumors of the blood where there is proliferation of the certain lineage of the blood cells. It could be usually the white blood cells, and very rarely red blood cells and
generally
platelets.
It's white blood cells.
It's when we talk about blood cancer in hematology, we generally mean leukemia. However, there are other blood cancers which the name is completely different from leukemia, like myeloma and lymphoma. Lymphoma is cancer of the lymph glands, while myeloma and leukemia both are blood cancers.
Okay, how common are leukemias?
Leukemias.
These are white blood cell cancer, which actually this is very common, isn't it?
Yes. So the leukemias, there are two main types for leukemias. Generally speaking, acute leukemias, which usually comes over a matter of weeks, and
a matter of weeks,
probably months, and they are usually proliferate quickly, and treatment should be given sooner rather than later. And there are chronic leukemias, and if you want to talk about the leukemias, the acute and the chronic, there are subtypes which like lymphoid leukemias and myeloid leukemias. And there are certain leukemias which are commoner in children than adults, and the other ways. But generally speaking, blood cancer leukemias in particular are they are commoner in elderly patients,
right? Okay, we'll talk more about leukemia and anemia and everything. So anyway, if anyone joined the program today, we are talking to a hematologist here. So our program is, we're supposed to talk about leukemia, anemia and deep vein thrombosis, and we'll talk more after a short break. See you there. Callers. completely Hi, welcome back to Iron Health Talk with Dr. Akram. In this program today, we're talking to a hematology consultant. His name is Dr. Abid Abu Sitar, and our main point is talk about leukemia. Let's talk about leukemia now, and after break, we'll talk more about anemia and deep vein thrombosis. Let's go back to leukemia. Okay, risk factors and who gets it?
Right, okay. I think the most independent risk factor for leukemia is unfortunately is age. So
age. Okay.
So of course there are certain leukemias.
What kind of age they get leukemia?
Well, it is when we talk about age, we talk about the age of greater than 65.
Greater than 65.
And it is, we talk about acute myeloid leukemia.
Acute myeloid
leukemia,
a kind of,
which is about 80% or more of the acute leukemias. As we talked earlier, there are
80% of them are
two main types of acute leukemia: acute myeloid and acute lymphoid. The acute
myeloid is 80%, the other one is 20%.
20%. Yes, and if we talk about the acute myeloid, because that's the commoner leukemia, it is
that comes for elderly people, as you said.
Yes. Well, the incidence in people who are less than the age of 65 is about 1 to 2 per 100,000, and the risk goes up to 10% to 20. 10 to 20 per 100,000 population. So it almost goes 10 times, but on overall, it's still a rare disease. So if we talk about the incidence in people who are over the age of 65, the incidence is about 10 cases per 100,000.
So 10 cases per 100,000 people. So it's not very common.
It's not very common. It's not as common as the cancer prostate or cancer.
What causes this leukemia?
Well, there's, majority of cases, there are no predisposing factors. It happens due to random
So it's
mutation.
not like you eat funny stuff, you smoke on this.
No. Well, there are some thoughts that smoking increases the risk of acute leukemia. But what we know for certain that the risk is increased by exposure to certain chemicals, including previous chemotherapy for other cancers, and radiation as well. But in majority of cases, there is no obvious
connection to
cause.
anything in the past.
It's due to random mutations happens in the stem cells.
And what kind of symptoms?
Okay, the symptoms, again, they vary a lot because the leukemia can cause shortage in the 3 types of cells we talked earlier. So it kind of, or it causes the combination of symptoms. So because it causes anemia, and
so leukemia causes anemia.
Of course, yes. Okay. Yes, and that can be presenting
red blood cells,
feature or symptom. It can cause infection. So patients, they can present with infections.
Yeah, that's right. Isn't it? Because white blood cells, which are the cells which protect, but if they're cancerous, they can't protect the body.
Yes, absolutely. And then it can present with low symptoms, platelets, so clotting, bruising or bleeding symptoms. In general, patients, they present with tiredness and fatigue.
Tiredness and fatigue.
Tiredness and fatigue and pallor. They become pale. They will notice, white, or somebody else, a friend or a family member, will notice that they become pale, and then they have a blood test. In extreme rare scenarios, but I come across this probably once a year, where people do have a routine blood test, and we are still
blood tests,
we are still talking about acute leukemias, while chronic leukemias, they may not cause any symptoms at all.
So chronic leukemia can be with you for a long time.
Yes, the chronic leukemias, they again, there are subtypes, but the commonest type, which we call CLL, not usually presents with no symptoms, and routine blood tests done, which will pick up high white blood cell count, and then further analysis will confirm they have So
this is picked up randomly when you do a test or something, they pick up. And you start treating. Okay, let's talk a little bit about the leukemia the children has. Is it a different one?
Yes, if we go back to what we said at the start, there are 2 types of acute leukemias. There's the acute myeloid leukemia, which is typically in elderly patients, and there's the acute lymphoid leukemia, which is relatively more common in children. And this is usually, or more than 90% of cases, are curable diseases. And
they are curable,
Yes.
It's not like 10, 20 years ago, what we thought,
absolutely,
like all die of blood cancer. It's not like in the films, isn't it?
No, it's it is a life-threatening disease, and it need to be treated. There is no 100% cure.
Okay, for children,
yeah,
what kind of symptoms they get? Like their parents, what do they have to be aware of?
well, they can present with, again, lethargy and lacking
Tiredness, yeah.
tiredness. They can present with bruises,
Bruising.
or they can present with lumps.
Lumps. Where do they see these lumps?
Well, usually in the neck.
In the neck, yeah.
In
Small
the neck.
lumps.
Yes, yeah. Well, I wouldn't say
grape
small
size?
lumps. Because the children, they get exposed to viral illnesses.
Yeah.
So it's much commoner to find a child with a lump due to viral illness
viral infection.
than due to leukemia. Leukemia is still pretty rare, even in the acute lymphoid leukemia in younger children.
So if the lump persists long time, and probably something to worry and something to show the GP.
Yes, absolutely.
Now you said there are treatment for leukemia. Not everyone dies of cancer, blood cancer now. What kind of treatments we have?
Well, again, this depends on the type of leukemia. It's very specific to the type of leukemias. Acute leukemias, the acute myeloid and in fact the lymphoid are treated with chemotherapy agents, and sometimes patients need to have stem cell transplant. But that depends on certain factors at diagnosis, which determines how aggressive the leukemia and what's the risk associated with the leukemias. But many leukemias, they are treated with chemotherapy. Chemotherapy without transplant.
Yeah.
And some patients, they need chemotherapy and they go into a transplant. There are many factors.
When you say transplant, what kind of transplant?
There are two types of transplant. Usually in leukemia, they do allogenic stem cell transplant, which
stem
means
cells.
Stem cell
Where
transplant.
do they take the stem cells from?
Stem cells are, over the last 20 years, now they are collected from the veins. It's like not quite similar to blood donation, but it is a big cannula in the arm. It goes into a machine, and the machine will separate the stem cells from the donor and return.
The stem cells are quite young cells, aren't
they? Yes. The stem cells are the precursors, or they are the earlier white blood cells, which have the characteristic to differentiate and to adapt to the environment and to change the whole immune system of the recipient.
Right. So do they take it from the patient or do they take it from somebody else?
No. In certain conditions, like myeloma, which we talked earlier, it's type. So
you will find a donor probably?
Yeah, no. In the myeloma, we do autologous stem cell.
So
it's from the patient.
And you clean them?
Yes, you clear the myeloma and then you collect stem cells and you put the stem cells back into the patient. While the allogenic bone marrow transplant, which is usually done in cases of high-risk leukemias,
high-risk
leukemias are collected from donors, and the typical donor is identical sibling.
So if they have a twin brother, twin sister, that's best one, or sisters, family?
Not necessarily to be twin brother or sister. It is identical sibling.
Siblings, right.
Sibling. And in fact, having the stem cell from
brother
a sibling,
or sister,
which is not an identical twin, is better because it will have an effect called graft versus leukemia effect.
Do the donors, do they have to be a same blood group, or they can be a different blood group?
No, they don't have to be the same blood group.
You just need a brother or sister who is happy to give you some blood.
HLA matched.
Yeah.
So at the level of the HLA, which is certain
HLA types, there's another type.
Tissue type.
Tissue types,
expressed on the stem cells, and it is very extended work to see the matching in the protein expressed on the cells.
Okay. Let's summarize. So can we give tablets?
Again, it depends on the type of leukemia.
Okay.
So chronic lymphocytic leukemia, you can give tablets.
You can give tablets.
But again, depending on the certain results in the at diagnosis.
Okay.
The alternative is intravenous. There is a lot of treatment now these days is under the skin, but
chemotherapy.
Chemotherapy.
Yeah.
But we are moving away from traditional chemotherapy, and we're using more biological treatment.
These are the new ones.
Yes.
Exactly.
Yes. Yes.
What are the new medications these days? What is like general? How can you explain our viewers?
Well, I will take an example of a condition, chronic leukemia, called chronic lymphocytic leukemia, which is, again, a lot of patients, they don't need treatment and they may enjoy the rest of their life without need of treatment. But in the past, we used to use treatment which makes people sick, lose their hair, admitted to hospitals. But now we're using biological treatment like a drug called ibrutinib, which is, we call it, the scientific name is BTK inhibitors. And the other example, which is chronic myeloid leukemia, we use Glyvic or imatinib, which it's a biological treatment.
It's again a biological treatment.
It's biological treatment, and it reverses the main abnormality in the abnormal chromosomes causing.
So you target the chromosome and
yes,
change. What's the name of that medicine?
Glyvic or imatinib. Yes, there's a lot of them at the moment. Yeah. And the first one which came to practice about 20 years ago called.
Right. And how do you take that? Is it like intravenous?
Just a tablet.
Tablet.
Just a tablet.
And this tablet goes to your chromosome and changes?
Yes, it just basically, it stops the enzyme which binds two chromosomes together, makes them very sensitive, and it breaks that bond between two chromosomes, chromosome 9 and chromosome 22. And it breaks that bond, and the breakage of this bond makes the proliferation of the white blood cells.
That's amazing. These new treatments are amazing. We're going to talk a bit more about it, and let's again, it's time for a short break. If anyone joined the program today, we're talking to a hematologist here, and we have so far covered leukemia a bit, and we have reached to the treatment, and we'll talk a little bit more about anemia and deep vein thrombosis in the next part of the show. So see you after break. Welcome back to Iron Health Talk with Dr. Akram. In this program today, we're talking about talking to a hematologist. So we're talking about leukemia, anemia, and DVTV. So far, we have covered leukemia, and let's go and talk more about anemia and deep vein thrombosis. This is really important. Okay, let's go back. What is anemia?
Okay, thanks.
We have covered
Akram. Yes, I think now, if you remember, we talked about the leukemia earlier, and we talked about a rare disease, which is in those who are less than the age of 65. It's about 1 to 2 per 100,000. But when we talk about anemia, it's very common.
It's a big subject.
Yes. I mean, specifically, the anemia is commonly due to iron deficiency. And
iron deficient anemia.
Yes, yeah. And that is the incidence is about 1 in 5 of women.
1 in 5 of women
of reproductive age, they get
during the
iron deficiency, mainly because of monthly blood loss during period. So this is a much commoner area of hematology, and identifying anemia is
actually anemia. We should have a full program on it. But
yes,
let's go through
absolutely,
shortly.
absolutely,
Let's
yes,
give them points.
yes,
Yeah.
yes, absolutely, yes. So it is. It depends on the type. Again, as you rightly said, it's a wide variety of
Okay.
disorders.
I'm going to hold you there, and there is a caller coming online. Hello.
Walaikum.
Walaikum assalam. What's your name?
I have one call. I just joined with your program. I don't know what it's about. But,
Today is about hematology. We're talking about leukemia, anemia, and deep vein thrombosis.
Okay. Can I talk about hernia?
Hernia, we had a question on hernia. No, we're just running short. Can you leave your number with the studio? I will call you back after the program.
Yes, sure, no problem. My number
please leave the number with the studio. I'll call you back. Okay, thank you. Okay, let's talk about anemia.
Yes, so anemia is again, anemia is a sign of an illness, but is not an illness, if you know what I mean. So there is, the commonest is anemia due to iron deficiency.
Iron deficiency, that's during the menstrual period.
Yes, yes, and there is anemia related to vitamins deficiency,
vitamin
like
deficiency,
B12 and folic acid, and this is not rare.
That used to be called for vegetarians. They used to have.
Yes, I mean it depends on the type. It can be seen in vegetarians who don't eat meat at all, and it can be seen in people with malabsorption, like celiac disease, and it can be seen. Yes, but in alcoholics, it just indirectly related to nutrition because they don't eat balanced diet. And there is finally the pernicious anemia, which is an autoimmune problem where your blood patients cells, they don't absorb B12 because of autoantibody interfering with the absorption mechanism. And of course there are other types of anemia like thalassemias, which is due to hereditary problems,
anemias,
and there are anemias due to, or we call them autoimmune hemolytic anemias, where the body starts to destroy the red blood cells, and anemia can be caused by chronic illnesses as well, and the best example for that is anemia in people with chronic kidney disease. In particular.
Okay, let's talk. Let me join this caller quickly. Hello. Yes, please go ahead, sir.
Yes. Would you be able to? Am I on live?
You are on the line, yeah.
I can't hear you very well.
I can hear you very well. You're on the line.
Okay. Would it be possible you can call me back? Can I leave my number?
Yes. If I get the number, everybody will know it. Would you like to give it to the studio?
I want to talk. If you can call me back, it'd be better.
Yeah, I'll call you back. Yes.
Have you got my number?
No.
Can I leave it to the?
If you can leave it to the studio, please, studio, can you take this call back and get the number from this gentleman? Thank you very much. Okay. Signs and symptoms.
Yes, signs of symptoms of leukemia is mainly lethargy and lacking energy. If it's severe enough, it can cause, especially iron deficiency, it can cause hair loss.
Hair loss?
Yes, it can also cause palpitations.
Oh, palpitations.
Yes, these are the symptoms related to shortage of oxygen delivered.
Because your body is starved for oxygen, and it asks the heart to pump it. Heart
more.
Cannot pump.
Yes.
And it tries to pump faster.
Yes, and in fact can lead to shortness of breath.
Shortness of breath. And again,
that's again because of the lack of oxygen into the muscles and other organs.
Okay. If anyone has these symptoms, what is the next stop for them?
Well, if anyone, generally speaking, especially in this country, most people who goes to the GP for any reason, they will get
GP,
blood count.
Yeah.
And the blood count always, or almost always, shows anemia. However, it's important to point out that sometimes people, they are short of iron and they are still at early stage and they are not anemic and they will still get symptoms of anemia. So they will have normal hemoglobin, normal blood count. If you look at their blood count, it doesn't show anemia, but if you check the iron level, and if they lift, only if they are left and treated, they will become anemic after months or possibly years.
When the iron deficiency starts, they will start feeling the symptoms.
Well, not when they start. As soon as they start, it takes some time because our body has the reserve, and the resilience. So the deficiency can be compensated, but at some stage it will be.
Okay, that's the point you worry about. You go to the GP. Okay, and management. Yes, first of all, you need to identify the cause of iron deficiency. We are talking about iron deficiency anemia. And in a woman of reproductive age, if there is a good history of severe blood loss during the periods, you have to give iron replacement, and the patient should talk to the GP. Exactly. That could be given as a tablet.
Yes,
generally.
as a tablet. And usually the tablets is better to be taken away from food, preferably with orange juice, because vitamin C enhances the iron absorption.
So you don't take it with food because, again, food
it can cause side effects, and it may be poorly absorbed. And it won't be, because we naturally don't absorb iron very well.
Oh, okay. That's
so
very interesting.
If we eat about 15 grams of iron, we absorb 1 to 3 grams of iron.
Right, that's interesting.
So that's why it's better to take it. And sometimes people, they take the iron tablets and they don't absorb it very well when we have to give intravenous iron. But that's
very rare,
common,
isn't it?
Yes.
Okay, we we talked about the treatment here as well. Treatment it depends on the problem, isn't it?
Yes.
So, you look for
so we talked earlier about the iron deficiency anemia, while the B12.
B12 deficiency, you give B12?
B12 is, we ask about the diet, and of course we have to replace it. And the replacement for the B12 is usually by injections, and
that's a beautiful color injection. Is it pink or red or something like that?
Yes.
B12. Is it same still?
It's usually. I've never. We normally, it's the primary healthcare. Usually they give it, but it's worth mentioning that the B12 takes months to be depleted.
So you need to give it more, and the store will slowly build up.
Yes, and if you start treatment, the treatment has to be given lifelong.
Lifelong.
Yes.
Okay. Wonderful. Let's talk about DVT. We got only 5 minutes left, and deep vein thrombosis. How common is it? And let's talk, why is it important with COVID?
Yes. Well, deep venous thrombosis, it is a common scenario, is a common problem. The incidence is about 1 in 1,000.
1 in 1,000.
That's 1 in 1,000 of
very
people
common,
suffer of deep venous thrombosis, and it's very important to mention here that it's clot in the veins, not in the arteries.
Clots in the veins,
And when we talk, it's usually in the deep veins in the legs, the calf, or in the thighs. And
the thighs.
There are certain risk factors which makes the deep venous thrombosis commoner than other illnesses, or commoner in one person from the other. Again, we go to age. This age is another factor, and the other risk factor is having major surgery, which mainly involve the abdomen and
major
pelvis.
abdominal surgeries,
Yes.
and orthopedic surgeries.
And orthopedic
as well.
surgery like hip replacement and knee replacement.
And we give them anyway, as an anesthetic, we always give them blood thinning.
Yes, yes, that's why for patients who have major surgery, as we mentioned earlier, or patients who have general anesthesia lasting more than 30 minutes.
Okay, let's talk here. This is really important for our viewers here. How to prevent this deep vein thrombosis can even happen to our family people who are sitting down at home. They're watching a lot of TV or elderly people. How can they prevent it? What are the remedies we have?
There are, as you know, there is a primary prevention and secondary prevention. The secondary prevention, it means that if somebody got a clot, how to prevent them from having another clot in the future, while primary prevention, how you prevent it from before
Not
it
happening,
happens. Yes. The primary prevention, i.e. before it happens, is generally, it's a general living standards.
Living standard.
You have to adopt to prevent it, like avoiding dehydration and exercises. And
exercises prevent dehydration,
Yes, and also stopping smoking.
Smoking is again, one of the causes,
And of course, the other preventative methods is when the patient comes to the hospital, then the doctors have to,
of course,
do a risk assessment and give them blood thinners, injections, or tablets to prevent the risk of clots. That is, we call it primary prevention, so it doesn't happen, of course.
What about with air travel? Especially when you're flying long distances from here to Bangladesh or Sri Lanka, it takes about 10 to 12 hours.
Well, this is very debatable issue, and we don't think it is a major trigger factor. And however, some patients, they can suffer of that, and I think these patients, they have probably an underlying factor which didn't show itself yet, either hereditary or an acquired factor. But on its own is not a high risk factor, and if someone presents with thrombosis after long haul flight, the doctor should assess for another hidden factors, such as genetic problems. Or any other chronic disease.
Thank you very much. It's an amazing talk. I think we have covered really important points here. Dr. Abid Abu-Sitar, consultant hematologist and hemato-oncologist. It's a very fruitful program. We talked about leukemia, anemia, and we covered deep in thrombosis. If you have any further questions, you can always write to us on our Health Talk with Dr. Akram YouTube channel, or you could always write to us on our Facebook link, Twitter, Instagram. We'll come back to you with more details. And for all of you for being with us today, thank you very much, and we'll see you in a similar program next week. Until then, look after yourself. Thank you.